Magnetic resonance imaging. Over the last 20 years, MRI has become an integral part of the imaging arsenal with ever-expanding indications. MRI relies on the fact that nuclei containing an odd number of protons have a characteristic motion in a magnetic field, precision, and produce a magnetic moment as a result of this motion. In a strong, uniform magnetic field, such as an MRI scanner, these nuclei align themselves with the main magnetic field and result in a net magnetic moment. A brief radio frequency pulse is then applied to alter the motion of the nuclei. Once the radio frequency pulse is removed, the nuclei realign themselves with the main magnetic field relaxation and in the process emit a radio frequency signal that can be recorded, spatially encoded and used to construct a grayscale image. The specific tissue characteristics define the manner and rate at which the nuclei relax. This relaxation is measured in two ways, referred to as the T1 and T2 relaxation times. The relaxation times and the proton density determine the signal from a specific tissue. There are large number of imaging sequences that can be used by applying radio frequency pulses of different strengths and durations. The image characteristic and signal intensity from different tissues are governed by the pulse sequence employed and whether it is T1 weighted or T2 weighted. For instance, fat, methemoglobin and mucinous fluid are bright on T1 weighted images, whereas water and thus the most pathological processes which tend to increase tissue water content are bright on T2 weighted images. Cortical bone, air, hemosiderin and ferromagnetic materials are of very low signal on all pulse sequences. In general, T1 weighted images are superior in the delineation of anatomy, while T2 weighted images tend to highlight pathology better. For added tissue contrast, intravenous gadolinium may be administered. Other more specific contrast media are also available for liver, bowel and lymph node imaging. MRI's exquisite contrast resolution coupled with a lack of ionizing radiation is very attractive in imaging, particularly of tissues that have relatively little natural contrast. MRI also has the advantage of multiplanar imaging as images can be acquired in any plane prescribed. It has traditionally been used extensively in the assessment of intracranial, spinal and musculoskeletal disorders. Allowing a global assessment of bony and soft tissue structures, more recent developments have resulted in new indications and applications. Today, MRI is commonly used in oncological imaging such as staging of rectal carcinoma and gynecological malignancies, identification and characterization of hepatic masses and assessment of the biliary tree, magnetic resonance cholangiopancreatography. MRI has become increasingly important in imaging of the small bowel. For example, in Crohn's disease, where repeated imaging with ionizing radiation can incur a significant radiation dose over time. Magnetic resonance angiographic techniques now allow non-invasive angiographic assessment of the cranial and peripheral circulation and cardiac imaging. Figure 14.12 T2 weighted axial magnetic resonance imaging scan of the head in a patient with a large left-sided oligodendroglioma arrow. We can differentiate this MRI picture from a CT scan, as in CT scan the cranium will be more brighter, the bone part of the cranium will be brighter. And this is T2 weighted image because the CSF appears, the fluid appears white. Sagittal T2 weighted image magnetic resonance imaging scan of the lumbar spine demonstrate disc herniation arrow in the patient with acute back pain. You can see the disc getting herniated. T2 weighted image, as in the spinal cord the fluid CSF appears white. 14.14 Coronal magnetic resonance imaging scan of the knee demonstrate extensive serpiginous areas of altered signal intensity in the distal femur and proximal tibia. Arrows are shown in the figure in a patient with bone infarcts secondary to oral corticosteroids. This magnetic resonance cholangiopancreatography demonstrates dilated central intrahepatic bile ducts and a stricture of the common bile duct in a patient with obstructive jaundice and cholangiocarcinoma. Diffusion weighted imaging is a relatively new type of MRI sequence that exploits the different rates of Brownian motion between different tissues. Tissues with greater cellular density have lower rates of diffusion of water molecules, and this difference can be exploited to distinguish benign and malignant lesions in a variety of organs, as malignant lesions tend to have greater density of cells. However, the availability of MRI is still relatively limited in comparison with other imaging techniques, and it is time consuming with respect to image acquisition and interpretation. Images are easily degraded by motion, including respiratory and cardiac motion. The use of respiratory and cardiac gating can minimize this, although bowel peristalsis can still be a problem. The long acquisition times require a cooperative patient who can lie very still, which can be difficult especially in claustrophobic individuals or those in pain. Furthermore, because of the use of high strength magnetic fields, patients with some metallic implants such as some aneurysm clips and prosthetic heart valves and those with implanted electronic devices such as pacemakers and defibrillators cannot be examined. Some newer implants may, however, be MRI compatible and patients with joint replacements can be studied safely. This is 14.16 maximum intensity projection image from a magnetic resonance angiogram demonstrate the abdominal aorta, common and external iliac arteries as well as part of pulmonary, mesenteric and renal vasculature. Summary 14.6 magnetic resonance imaging, the strengths, evolving use and the weaknesses. Strengths: no ionizing radiation, excellent soft tissue contrast, best imaging technique for intracranial lesions, spine, bone marrow and joint lesions. Evolving use: staging, MRCP, MR angiography, breast malignancy, pelvic malignancy, cardiac imaging, MR enterography, diffusion weighted imaging. Weakness: absolute contraindications, ocular metallic foreign bodies, pacemakers, cochlear implants, cranial aneurysmal clips. Relative contraindications: first trimester of pregnancy and claustrophobia. Long scan times, so patient may not be able to keep still, especially if in pain, limited availability and expensive. Moving to nuclear medicine, in other imaging techniques using ionizing radiation such as CT and conventional radiography, the individual is exposed to ionizing radiation from an external source and the radiation transmitted through the patient is recorded. In nuclear medicine, however, a radioactive element or radionucleotide such as technetium, gallium, thallium or iodine is administered to the patient as part of a radiopharmaceutical agent, and a detector such as a gamma camera is then used to record and localize the emission from the patient, thus forming the image. The radionuclide is chosen and coupled with other compounds such that it is distributed and taken up in the tissues of interest. Therefore, a variety of radionuclides are required for imaging of different tissues. Nuclear medicine also differs from other means of imaging which are largely anatomically based, as it also provides functional information. Radionuclide imaging is widely used in bone imaging with very high sensitivity for assessing metastatic disease, metabolic bone disease, established arthritis and occult infection and traumatic injuries. You can see in 14.17 bone scintigraphy in a patient with carcinoma of breast illustrates bony metastatic deposits involving multiple vertebrae, the skull, pelvis and ribs. Although many of these applications are being replaced by MRI, in genitourinary disease, dynamic imaging can be performed to assess renal perfusion and function, including obstruction, investigate renovascular hypertension and evaluate renal transplants. Radionuclide imaging is also commonly used in thyroid and parathyroid disorders, ischemic cardiac disease, detection of pulmonary emboli and assessment of occult infection and inflammatory bowel disease. Positron emission tomography is an extension of nuclear medicine in which a positron emitting substance such as 18-fluoroxy is tagged and used to assess tissue metabolic characteristics. The most commonly used radiolabeled tracer is 18-fluoro-2-fluoro-2-deoxy-D-glucose FDG, although other tracers can also be used in order to assess metabolic functions such as oxygen and glucose consumption and blood flow. Radioisotope decay causes the emission of a positron which subsequently within a few millimeters collides with and annihilates an electron to produce a pair of annihilation photons. The drawback have been high cost, very limited availability and relatively low spatial resolution. The last of these has been addressed by PET or CT systems combining simultaneously PET imaging and CT, allowing the two sets of images to be registered so that the anatomical location of the abnormality can be localized more precisely. Summary 14.7 radionuclide imaging, strengths and weaknesses. Allows functional imaging, allows imaging of the whole body. Bone scan has a high sensitivity for metastatic bone diseases, fractures and infections. PET scanning is valuable in the detection of metastatic cancer. Weaknesses: specific agents are required for specific indications. Often non-specific and an abnormal result may require further imaging, generally poor spatial resolution. Imaging in orthopedic surgery. Introduction. Imaging is an intricate part of musculoskeletal diagnosis, and image-guided, minimally invasive techniques also play a major role in treatment. In broad terms, radiographs are the best method of looking for bony lesions or injuries. MRI shows bone marrow disease, muscle tendon, and soft tissue disorders, and ultrasound has better resolution than MRI for small structures, with the added advantage of showing dynamic changes. CT enables a visualization of the fine detail of bony structures, clarifying abnormalities seen on plain radiographs. There are occasions when a combination of techniques will be important and due consideration should be given to reducing the ionizing radiation burden to the patient using ultrasound and MRI as primary investigations whenever appropriate. Summary 14.8 Types of imaging. Radiographs are the best first line test for bone lesions and fractures. MRI is good for diagnosing bone marrow disease, occult fractures, and tendon and soft tissue disorders. CT enables visualization of the fine detail of bony structures. CT gives the best 3D image, three-dimensional information on fractures. Ultrasound has better resolution in accessible soft tissues and can be used dynamically. Ultrasound is the best method of distinguishing solid from cystic lesions. Ultrasound is the only method for locating non-metallic foreign bodies. Ultrasound is the best method for detecting muscle hernias. Skeletal trauma. Musculoskeletal trauma is best imaged by an initial plane radiograph. All skeletal radiographs should be taken from two different angles, usually at right angles to each other. This is important in trauma because a fracture or dislocation may not be visible on a single view. Occasionally and in specific locations such as the scaphoid, more than two views are routinely performed. If this fails to make a clear diagnosis or if there is suspicion of soft tissue injuries, then cross-sectional studies are indicated. Increasingly, in the assessment of spinal trauma, CT is replacing radiographs as the first line investigation for two main reasons. The first is that the sensitivity of CT is superior. The second is that it is quicker, enabling treatment to commence sooner. Figure 14.18 Anterior posterior radiograph of wrist. In the first image A, in a patient following a fall, does not show an acute bony injury. It is only on second view that a fracture of the dorsal cortex of the distal radius is visualized. So this is the reason why we take images at two angles at 90 degrees. Summary 14.9 Trauma imaging. Initial imaging Summary box 14.9 Trauma imaging. Initial imaging is either radiography or CT. At least two views are needed for radiographs. Use CT for spine, intra-articular or occult fractures. Axial CT images alone may fail to diagnose some fractures, so three-dimensional reformatting is important to prevent errors. Sections should be thin, but care must be taken to not to cover too wide an area as the radiation burden may be excessive, particularly with multi-slice CT. Degenerative disease, synovitis. Radiographs are usually the first line imaging investigation performed for the examination of joints. Typical changes of a degenerative or an erosive arthropathy are well known and understood. However, early arthropathy will be missed on radiographs, and with the advent of disease modifying drugs, it is important to detect early synovitis before it is even apparent on clinical examination. Gadolinium diethyl triamine pentaacetate enhanced MRI DTPA enhanced MRI is the most sensitive method for detecting synovial thickening of numerous joints, but ultrasound is also sensitive, albeit more laborious to perform. Ultrasound shows effusion and synovial thickening clearly and shows the increased blood flow around the affected joints without the use of contrast agents. In figure 14.19, axial T2 weighted fat suppressed image of the wrist in the patient with rheumatoid arthritis demonstrates synovitis manifested as increased signal dorsal to the carpal bones. Ultrasound of wrist shows thickening of, in the A image shows thickening of tissues on the dorsal aspect of the radiocarpal joint, and in B there is increased flow on power Doppler ultrasound in this patient with wrist synovitis and rheumatoid arthritis. Articular cartilage damage. Articular surface disease is difficult to detect using non-invasive techniques, MRI is probably the best method, although it is not sensitive to early chondral changes. Higher field strength magnets 3 Tesla and above with dedicated surface coils provide more precise assessment. However, MR arthrography is currently the imaging gold standard. Saline mixed with dilute quantity of gadolinium DTPA is introduced into the joint by needle puncture, which is followed by an MRI examination. Using this technique, more subtle changes in the articular surface can be seen, including thinning, fissuring, and ulceration. However, early softening of articular cartilage will not be visible. MR arthrography is also useful for detecting labral tears in the shoulder or hip and in the assessment of patients who have undergone a previous meniscectomy. The triangular fibrocartilage of the wrist is also difficult to assess fully without MR or CT arthrography. This image 14.21 coronal magnetic resonance imaging of the knee demonstrated a focal osteochondral abnormality of the medial femoral condyle with full thickness loss of the articular cartilage and abnormality of the subchondral bone. Figure 14.22 coronal CT arthrogram of the wrist showing a central perforation of the triangular fibrocartilage with contrast extending into the distal radioulnar joint and radiocarpal articulation. In the shoulder, rotator cuff trauma and degenerative changes can be studied using ultrasound or MRI. In experienced hand, ultrasound has a high accuracy rate because image resolution is better and because the mechanical integrity of the cuff can be tested by dynamical stressing it. MRI has the advantage of being able to show abnormalities in the subcortical bone. In the majority of arthropathies and degenerative disorders, serial imaging is useful. Changes in films taken weeks or months apart are far easier to see and interpret than a single snapshot study. Aggressive bone disease. The radiograph is the first imaging technique for destructive lesions in bones. There is considerable experience required in the interpretation of these films, especially with regard as to whether the lesion is benign or malignant. Summary box 14.10 Imaging techniques for joint disease. Radiographs are good for assessing established articular disease. Synovitis can be detected using ultrasound or contrast enhanced MRI. Early damage to articular cartilage is difficult to image by conventional methods. Rotator cuff lesions are best studied using ultrasound or MRI. Destructive lesions are best studied first on plain radiographs. MRI is best for staging tumors. Biopsies can be guided by fluoroscopy, CT or ultrasound. Figure 14.23 Ultrasound of the supraspinatus tendon identifies a special tear in the tendon which predominantly articular sided but with a component that is nearly full thickness. Radiographs are also vital in assessment of soft tissue calcification in tumors of muscle, tendon and subcutaneous fat. When a lesion is detected, there needs to be an early decision as to whether this is benign or malignant. If there is a suspicion of malignancy on the radiograph or any uncertainty, then local staging is indicated. This is best performed by MRI of both bone and soft tissue lesions. At this stage, it is likely that a biopsy will be indicated and preferably under image guidance. Soft tissue and bone biopsy needles may be guided by CT, ultrasound or interventional MRI systems. The route of puncture should avoid vital structures and must be agreed with the surgeon, who will perform the local excision if the lesion proves to be malignant. Care should be taken to avoid contaminating other compartments. In all circumstances, samples are best sent for both histopathological and microbiological examination. It may be difficult to tell on imaging whether or not a lesion is infected, and histology often provides a clear diagnosis in inflammatory conditions. Bone scintigraphy is useful in detecting whether a lesion is solitary or multiple, although whole body MRI is becoming available. Figure 14.24 Anterior posterior A and lateral B radiographs of the left knee in a young patient with knee pain is shown. There is a mixed lucent and sclerotic lesion of the distal femur with breach of the cortex medially and soft tissue extension seen anteriorly and posteriorly. The location and appearances are consistent with osteosarcoma. Figure 14.25, coronal T1 weighted image is shown in A and axial T2 weighted image fast suppressed is shown in B. Images through the distal femur of the patient in figure 14.24, the same image, illustrates the bony area involved, the soft tissue extent of the tumor, and the relationship of the neurovascular structures to the mass. Summary box 14.11, imaging of aggressive lesions in bone. Plain radiographs are important as a first investigation. MRI is best for local staging. Bone scintigraphy or whole body MRI for solitary or multiple lesion determination. CT detects lung metastasis. Fluoroscopy, CT, MRI or ultrasound may be used to guide the biopsy. Mass lesions in muscle and soft tissue are examined by ultrasound, which can be diagnostic in majority of cases, thereby avoiding the need for further imaging. This is most often the case when a lesion is purely cystic, and as most soft tissue masses are cystic, ultrasound is very effective screening test. There are occasions when no mass lesion is found at the site of concern, and then reassurance can be offered if the ultrasound examination is normal. This effectively excludes soft tissue neoplasia. A reasonable protocol is to perform ultrasound on all palpable lesions to exclude cysts and on patients without any identifiable mass, and to proceed to MRI only when there is a solid or partly solid element to an unidentifiable lesion. Tumor vascularity is best assessed by Doppler ultrasound. It can be studied by intravenous gadolinium, DTPA enhanced MRI. However, this is a more expensive and invasive technique, providing no more information than Doppler ultrasound. Summary box 14.12, imaging of soft tissue lesions. Ultrasound is the best for screening. It is often the only imaging required. MRI is best for local staging and follow-up. Doppler ultrasound can assess vascularity cheaply and effectively. Ultrasound is useful for biopsy. Infection. In the early stages of joint infection, the plain films may be normal, but they should still be performed to exclude bony erosions. In case a painful joint is the first sign of an arthropathy, ultrasound examination is the easiest and most accurate method of assessing joint effusions. Although when an effusion is identified, it is not possible to discriminate between blood and pus. Aspiration guided by ultrasound is the best method of making this distinction. MRI may be required to assess early articular cartilage and bone involvement. Radiographs should also be used to examine patients with suspected osteomyelitis. Although they may not detect early infection, they will demonstrate or exclude bone destruction, calcification and sequestrum formation. CT may be needed to give a cross-sectional view in order to assess the extent of bony sequestrum. MRI is perhaps the most sensitive method for detecting early disease and is the preferred technique to define the activity and extent of infection, as it shows not only the bony involvement but also the extent of edema and soft tissue involvement. Abscesses may be detected or excluded, and subperiosteal edema is readily visible. MRI can be used as a staging procedure to plan treatment, including surgical intervention. Serial examinations can be used to follow the response to intravenous antibiotics and are very useful in the management of complex osteomyelitis. In case of negative or equivocal MRI, nuclear medicine techniques such as bone scintigraphy can be very sensitive, and specialized studies using tracers such as gallium citrate or indium labeled white cells increase specificity. So this for 14.26a, A image, the plain film of this 13-year-old are close to normal. On close inspection, there is a fine periosteal reaction on the fibula. In the B image, the coronal T1 weighted magnetic resonance image shows little more, but in the C, the coronal fast STIR, short tau inversion recovery images, and D, axial T2 fast spin echo with fat separation shows the edema in bone as white and the extensive periosteal fluid with tissue inflammation. The diagnosis is acute osteomyelitis. Summary 14.13, imaging of potentially infected bone and joint. Plain radiographs may be needed to exclude bone erosion. Ultrasound is sensitive for an effusion, periosteal collections and superficial abscesses, and can be used for guided aspiration. CT is useful in established infection to look for sequestrum. MRI is useful to define the activity of osteomyelitis, early infection and soft tissue collections. Bone scans are sensitive but of low specificity. Complex nuclear medicine study are useful in negative MR examinations or equivocal cases. Metabolic bone disease. Plain radiographs should be the first image of patients with metabolic bone disease. They may detect the subperiosteal erosions in hyperparathyroidism or more commonly the osteopenia in osteoporosis, but they cannot be used to quantify osteoporosis. The apparent density of the bone on the film is linked to the penetration of the rays among other variables as well as the bone density if a quantitative method is needed. However, bone mineral density using dual X-ray absorptiometry DEXA is the most accurate and practical. However, fractures will cause erroneous high readings and they tend to occur in the vertebra used for DEXA measurements. Quantitative CT is an alternative technique, although this is less readily available. Ultrasound transmission measurement in the extremities has its advocates as it arguably measures factors that better represent the strength of bone rather than its density. Its limitations are that it cannot be used to study the vertebrae or hip, and these are the sites where osteoporotic fractures occur most frequently. MRI may be useful in detecting fractures and is an essential prerequisite to percutaneous vertebroplasty.